Thank you everyone again for joining our cardiology grand rounds. This week we're very fortunate to have Dr. Jennifer Tremmel with us, presenting on the evaluation and treatment of angina with non-obstructive coronary arteries. So just a little bio, Dr. Jennifer Tremmel is an interventional cardiologist in the Division of Cardiovascular Medicine at Stanford University Medical Center. She is the endowed medical director of women's heart health at Stanford and conducts research on sex differences in cardiovascular disease. Much of her work has focused on patients with angina in the absence of obstructive CAD. This includes studying endothelial dysfunction, microvascular dysfunction, and myocardial bridging in patients with stable angina, and myocardial infarction with non-obstructive coronary arteries, or INOCA, and spontaneous coronary artery dissection in patients with acute angina. She also has been an early adopter of the transradial approach and is a national expert on the topic. More recently, she started the Chronic Total Coronary Occlusion CTO program at Stanford, for which she is joining us right after a CTO case today, and has contributed to the field by demonstrating that the radial approach and same-day discharge are readily achievable in complex PCI. Again, I mentioned that she'll be presenting on the evaluation and treatment of angina with non-obstructive coronary arteries. I will mention that this is very timely. I was just reading Jack and saw your state-of-the-art review on comprehensive management of INOCA, so we're very fortunate to have you with us today. So with that, I'll let you take it from here.
Thank you. Yeah, I'm sure everyone stayed up late reading the article to be prepared for grand rounds. So if you did, you don't actually need grand rounds today, but so pleasure to be here, and always happy to be speaking with my neighbors, and many of you I know, so hello to all of you. I'm going to talk about INOCA today, and these are my disclosures. I think this is a nice talk to have early in the year, so I'm glad we're doing it kind of as the fellows are starting, because the first thing I kind of want people to do is start to think about coronary artery disease differently than we traditionally have. And so it's good to start your fellowship off like this. So traditionally, we think of coronary artery disease as an obstructive disease or a plaque-based disease. And if you break it up into stable coronary artery disease, you have traditional stable ischemic heart disease. And if you look at patients who are unstable or acute, then you have a traditional ACS or MI. But in fact, the way we need to think about coronary artery disease in this day and age is that there's also non-obstructive coronary artery disease. And so if you have stable symptoms, but you have non-obstructed coronary arteries, you have INOCA, which is what we'll be talking about today. In the old days, this was called Syndrome X because they didn't know what it was, but we have several etiologies now that we can test for and treat accordingly. If you have unstable or acute symptoms, then you have INOCA, which we won't be talking about today, but MI with normal coronary arteries. And unfortunately, this has often been, you're fine, right? So people will do the angiogram when somebody comes in with an MI, the coronaries look normal, they'll say, you're fine. In fact, I saw a woman in clinic just yesterday who had INOCA, and she was told exactly this, you're fine. But we know that's not true. These patients actually have also lots of possible etiologies and a worse prognosis than they otherwise would if they did not have an MI. So with that, INOCA is so angina with normal or non-obstructive coronary arteries. And when we say non-obstructive, it's typically less than 50% stenosis. We know that angina itself is very common, with up to 11 million American adults reporting current angina or a history of angina. And although many patients have obstructive CAD, approximately half of those that undergo evaluation for suspected ischemic heart disease have non-obstructive coronary arteries. And even if you focus only on those patients that had inducible ischemia, this is from the ischemia trial, over 20% still have non-obstructive coronary arteries. So in other words, these patients are extremely common. You guys are going to see these patients in clinic throughout your fellowship. But unfortunately, we have traditionally kind of disregarded these patients, and we haven't really done a good job by them, as I'll go through. I think because they haven't really fit into our traditional paradigm which again, we need to revise and think about these patients differently. So who are these people? So these are usually normal patients. These are not crazy patients, although sometimes they've been made crazy by their condition, but these are normal patients who are living a normal life, but now have angina. And the vast majority of them will actually have typical angina. And then a minority of them will have atypical angina. And typical and atypical here are being defined by the Diamond-Forrester criteria, which may or may not be great for INOCA patients, but typical angina, that they have chest pain, comes on with physical exertion, goes away with rest, or nitro, right? And atypical is having two of those features, so substernal chest pain, and then comes on with physical exertion or emotional stress, and or relieved with rest. These patients have had their symptoms for a long time. We say at least 3 months, but more commonly, these patients will have complained of chest pain for years, and they're more often women than men in about a 3-to-1 ratio. They don't have other causes of angina, so no pulmonary hypertension, HOCM, valvular heart disease, pericarditis, none of those. And then they've typically had at least one and generally multiple stress tests. They've often had at least one, sometimes multiple coronary angiograms, and people haven't figured out what's wrong with them. They've often been tried on several medications, and ultimately they've been told, well, nothing's wrong, but they continue to be limited by their chest pain. So as an example, a typical INOCA patient might look like this. So a 42-year-old woman, no cardiac risk factors, comes into your office for a consultation. She's been having chest pain for 2.5 years. She describes it as substernal, occasionally going into her left shoulder and neck. It can come on with exertion, but also at rest. And if it occurs, she simply tries to relax until it goes away. She's put on 15 pounds over the last 2.5 years because she had to stop exercising because of her symptoms. She reports being constantly tired. She had seen another cardiologist about a year prior. They did a Holter echo nuclear, all were normal. She had several ER visits. They never found anything. She basically stopped going to the ER because it kind of became demoralizing to go to the ER. She was occasionally tearful during her exam or during her appointment, and her physical exam is unremarkable. So this is very classic sort of presentation. And if you listen to her chest pain, it's actually typical angina. And unfortunately, when people kind of listen to this story, they say, well, this is atypical angina, or this is non-cardiac chest pain. But if you listen, the angina itself is typical, right? And just because if you think ahead and say, I don't think she has obstructive disease, which we know she doesn't, that doesn't change that her chest pain is actually typical angina. And so it actually behooves us to figure out why she has this. So if you look at the evaluation of these patients with angina, and especially women, they'll come in with these angina-like symptoms. And what often happens is, the physician says, well, maybe it's GERD. They give them a PPI. That doesn't work. She comes back still having symptoms. Maybe it's asthma. Here's an inhaler. That doesn't work. She comes back. Okay, well, we'll get a stress test and see if it is anything. If it's positive, we're all like, great, we'll do an angiogram, right? We know what to do with a positive stress test. But if it's negative, then people start thinking, well, this person's crazy. Maybe she needs to relax. Let's give her a little Xanax. Maybe she still keeps coming back with this chest pain, and you're like, fine, your stress test is negative, but I will do an angiogram to rule anything out. You do an angiogram on the very off chance that it's positive. We're all happy again because we know what to do. We put in a stent, but most likely this is going to be negative. And unfortunately, at this point, we're like, this person's definitely crazy, right? Because they don't fit, again, into our paradigm. And unfortunately, this is the way these things go. I hear patients describe this over and over. We now have a little bit of objective data to kind of support that as well. So Martha Gulati did a survey of INOCA patients, 300 of them, and found that 92% reported chest discomfort that was triggered by physical exertion, and 92% had chest discomfort, and 73% was triggered by physical exertion, 80% by emotional stress. And these patients, 94% had multiple consultations before being diagnosed with INOCA, with 50% having seen 3 or more cardiologists. Only 6% were diagnosed with INOCA at their first consultation. All of them had undergone some diagnostic testing, with 93% having non-invasive imaging and 73% having a cath. And for a quarter of them, it took 3 to 10 years to get a diagnosis. And for 10%, it took over 10 years. And of those having been seen in the ER, 70% left without any treatment. 78% were told their symptoms were non-cardiac. 54% were told their symptoms were due to GERD. And 30% had actually undergone endoscopy. And 32% were referred to a psychiatrist, with 42% being prescribed an antidepressant. So unfortunately, this has a big impact on their quality of life, as you can imagine. So in asking them, how's your quality of life, over half report their quality of life as fair or poor. And they also report a decrease in their mean functional capacity from 8.6 to 5.6 MET. And with each decrease in METs of their functional capacity, you see that they lose 3 days a month of physical health, 2 days of mental health, and another 3 days of inability to perform recreational activities. And so this has a profound effect on them. 81% report adverse impact on their home life, 80% on their social life, 70% on their mental health, 70% on their outlook on life, 56% on their sex life, and 54% report an impact with their partner or spouse. And in terms of work and disability, 70% report adverse impact on their work life, and 3 out of 4 have either reduced work or stopped work completely. So this has a huge impact, and these are people we really need to do better with. These patients are struggling, and we really haven't made it easy for them. So there was this small survey, and they looked at some of these patients, and they kind of found 4 themes. And I would say this is exactly, again, the stuff we hear in clinic. These patients are distressed because they have symptoms and there's an unknown cause. And to them, there's a threat from these unknown symptoms to their personal and professional identity. They report a long journey to reach a definitive diagnosis. They report negative healthcare interactions that ultimately incur further uncertainty and trauma. They find, though, when they get a diagnosis, that this actually enables a path forward. It provides them with relief and validation, a sense of empowerment. And a lot of them really, after they get a diagnosis, want to commit to promoting awareness and supporting other women. I thought this was interesting. Found this in a journal, and you don't need to read the details, but they basically took an INOCA patient and watched her through the medical system over time. And this is the journey map. So this is basically what we made this patient go through to ultimately get a diagnosis, which seems really ridiculous. And so I was like, well, I wonder what a journey map would look like for somebody with obstructive disease. And so I created it. I think it's something like this, right? You get chest pain, you go to the cath lab, you get a stent. A lot easier. So hopefully we can ultimately make these journey maps shorter for INOCA patients. So a lot of people are like, wow, this sounds terrible, but what am I supposed to do about it? So first of all is just learning to identify these patients, right? Giving them the benefit of the doubt, hearing that they have what sounds really like angina, and saying there's probably something here I'm missing. And then either doing invasive assessment at your own center, or getting them to a place where somebody can do the invasive assessment. So getting them a diagnosis, right? This is what we really need to do. So what are the underlying etiologies of INOCA? So having angina and normal coroners doesn't just mean you have microvascular dysfunction. I think people are starting to figure this out, but it used to be, we thought it was nothing, and then everybody decided, oh, if you have angina and normal cores, it's microvascular dysfunction. And that's one of the possibilities, but that is not the only possibility. And until you test for it, you can't say this person has microvascular dysfunction. So INOCA is a working diagnosis. There are several etiologies that you can look for. This is from the Cormica group describing 4 endotypes. This is a little simplistic, I think, but it's a good place to start. So in terms of endotypes, you can have microvascular angina, which involves traditional kind of microvascular dysfunction, which is adenosine-based dysfunction, where you get rarefaction and kind of loss of the capillary bed that can cause their angina. And microvascular angina can also include vasospastic angina at the microvascular level. And then you can have epicardial vasospasm, so spasm at the epicardial level. And then you can have a mix of these. And then this group, just said type 4 is non-cardiac, which is not an endotype as far as I'm concerned. And I would add then at least type 4 is myocardial bridging, which has really kind of been the forgotten endotype. I think people are starting to figure this out and starting to look for this. But this is another etiology that we will see in evaluating these patients. So in doing the diagnostic evaluation, most patients are going to start with a stress test, and traditional stress testing can certainly be helpful for ruling out obstructive disease, but it's important to recognize that it is insufficient for identifying the occult causes, meaning that it doesn't predict if your patient's going to have microvascular dysfunction or spasm. And so if the stress test is negative, you can't tell your patient there's nothing wrong with their arteries, nor does having a negative stress test preclude having this invasive evaluation. Because a good proportion of these patients, we will not see a positive stress test. And a lot of that is probably because stress tests are really designed to look for transmural ischemia in, a large coronary bed. And these patients are often having subendocardial ischemia, which is likely not getting picked up on echo, distress echo, and nuclear perfusion scan. It's also worth noting that you can, with pretty good accuracy, identify the presence of a myocardial bridge by echo. So if you look at the stress test shown here, what you'll see is that there is focal septal buckling with apical sparing. I don't know where the rest of my sentence went, sorry. And so basically the septum is buckling in there, but the apex is still coming in. And if this were an LAD ischemia, you wouldn't see the apex coming in. So that's a unique finding. Our fellows certainly learned how to identify this, and it can give you a clue. It doesn't mean that the bridge is hemodynamically significant, but it actually is pretty good at predicting the presence of a myocardial bridge. And then you can do CCTA or angiography to confirm. So there are non-invasive ways of testing for INOCA, although all the non-invasive methods can, at this point, really only look for microvascular dysfunction. And so you're not going to be able to determine if the patient has vasospasm by this. You're not going to be able to determine if they have a hemodynamically significant bridge. Cardiac PET has been tested the most and looking at myocardial blood flow. And then we have cardiac MRI that can look at the myocardial perfusion reserve index. And even on contrast echo and with Doppler echo, you can kind of calculate the CFR and look for microvascular dysfunction. So these are options, but again, it's limited because it's only looking for microvascular dysfunction. And in these patients, even if you found it, it doesn't mean they don't have one of the other causes as well, right? Because some patients have more than one etiology. So what we really recommend is comprehensive testing and invasive comprehensive testing. And so this involves looking for endothelial dysfunction and spasm. All right, sorry about that. So we're just getting to the meat of all this stuff. So, all right, so here we were. So acetylcholine testing, and then let me go big here. And then we look for myocardial bridging as well as diffuse plaque, and we do that with intravascular ultrasound. If there's a bridge present, then we will do physiology testing with diastolic FFR using dobutamine to get them to target heart rate. And then we test for microvascular dysfunction, which again is the structural kind where we look for adenosine-based CFR and IMR values. Is the volume okay?
Yes, it is.
Okay. Okay, so how do we do this? So first of all, most of these we actually schedule ahead of time. So we do these Thursday morning. I do 2 to 4 cases a week. So there's a lot of these patients. And you can do them ad hoc, but it's a little bit easier just kind of that you have your time to do this. We hold any vasoactive drugs for at least 24 hours prior. I typically go through the groin here, although I love the wrist. We do give vasodilators when we go through the wrist. And in my opinion, it does affect the testing to some degree, although this is controversial. So when we do the spasm testing, we start with 20 mics of acetylcholine. And then I do 20 mics, 50, 100, and 200. That's a bit excessive. I think what we decided on for kind of out in the community is 20 mics and 100 mics. We did show in a paper that in men you may actually still see a response that you didn't see at 200 mics. So in some patients, if you haven't seen a response, it's reasonable to go up higher just to see if you do get a response. The definition of endothelial dysfunction is a little bit controversial as well. I've always used the Mayo definition, which is that you have a decrease in the epicardial vessel by at least 20% compared with baseline. The Y study actually used any sort of constriction of the vessel as endothelial dysfunction. Vasospasm, we actually have a better, kind of more universal definition, which is that if the vessel spasms greater than 90%, then this is considered vasospasm. So basically somewhere between 0 and 20 and 90%, that's called endothelial dysfunction. If you do this and you get no constriction of the epicardial vessel, but you have angina and ST changes, then you need to be thinking that you have endothelial dependent microvascular dysfunction, which is basically microvascular spasm. So the small vessels are spasming, but the epicardial vessel is still open. And you will see this in some patients. So what does this look like on angiography? So on the left is normal, and then on the right, this is after we gave 50 mics of acetylcholine, and you can see the vessel actually got bigger. So that's what we would expect with acetylcholine, is that the vessel will get bigger. In a patient that doesn't have normal endothelial function, the left is normal, and then after 50 mics, you can see that she got diffuse spasm, and I would say down, distal to the apex or at 90%. So this patient has spasm. So the next thing that I do then is put down a workhorse wire and do intravascular ultrasound. This achieves a couple of things. One is it looks for atherosclerosis, and you can of course have diffuse atherosclerosis that can limit flow and actually cause a low FFR that you don't always appreciate on angiography. You just see kind of a smaller vessel, but not necessarily a tight occlusion if it's kind of diffuse and circumferential. And the reason I started IVUSing all these patients when I started doing this testing toward the end of my fellowship many years ago was because I was interested in sex differences in plaque, burden, type of plaque, that sort of thing. And in doing this, we saw a lot of myocardial bridges, which is not something that was on my radar. I was basically taught, like everyone else, that they don't matter. But I ended up seeing a high proportion of bridges in these patients, about 60%, which is certainly higher than what we would expect in the normal population, which would be about 30%, which made me start to wonder if this was also a cause of chest pain in these patients. So disproportionately high prevalence, 60% compared to 30%. These can be difficult to diagnose. Certainly angiography is a poor way to diagnose a myocardial bridge. You often will not see it by angiography, and you do need intravascular ultrasound to fully rule it out. And then even if you find one, it doesn't mean it's causing symptoms, right? And so you need to be able to distinguish those that are incidental from those that are hemodynamically significant. And so the best testing we have right now was proposed by Javier Escaned over 20 years ago now, which is dobutamine diastolic FFR. And we've been looking at RFR, which may be a reasonable substitute and would be easier for people because there is no software for diastolic FFR. You actually have to calculate it, whereas RFR you can get on your normal CoreFlow system. So with intravascular ultrasound, you can get a lot of data. This is an example of an IVUS map that our IVUS core lab will make for our surgeons and any patients that ultimately undergo unroofing. And they'll actually hang this in the OR so they know exactly what they're doing in kind of digging this artery out. So very briefly on myocardial bridges, they're mostly in the LAD. Angiography is a poor way to identify them, as I said. The symptoms typically don't come on until the third decade of life, although we've actually studied kids at around age 10 to 11 who have symptoms. I've also seen people who didn't get symptoms until their early 70s. And so it's quite variable. And then these bridges are often associated with endothelial dysfunction or spasm, which is what you should have seen there in the picture. So you can see how the middle part of the artery there is spasmed. A lot of people, if they don't look for a bridge, they'll give acetylcholine. They'll say, oh, this patient has spasm, which they do, but they don't recognize that this patient not only has spasm, but they have a bridge with spasm. Gosh, I hope my computer's not freezing up. I'm gonna get some things to be.
It's still...
I think Mercury's in retrograde, so that's probably the problem. Okay, yay. All right, so, and then microvascular testing. So traditionally this involves measuring coronary flow reserve or CFR. And this can be measured through thermodilution, which is what we mostly do in this day and age. Also, traditionally it was done through Doppler, in which case it was coronary flow velocity reserve. And then we also test IMR, the index of microvascular resistance, which is with thermodilution, and the equivalent with Doppler is HMR. And this is done with adenosine. And basically you have a pressure wire, it measures pressure and flow. And coronary flow reserve, we're looking at flow at rest, and then we're looking at flow during hyperemia, and we're looking at the ratio. And we expect that the flow should increase by at least 2.5. And so if we see a CFR less than 2.5, this is abnormal. The index of microvascular resistance is using Ohm's law to look at resistance in the microvascular bed. So if you measure pressure at the distal coronary as well as flow, then you can calculate resistance. A normal microvascular bed has very low resistance, so that when you exercise or get stressed, those vessels open up and you get blood flow. High microvascular resistance or an IMR greater than 25 is abnormal. When you do this, the system that everyone's using now also will give you FFR, so it allows you to also rule out any epicardial constriction. So this is how it looks. I don't know if you guys probably have Corventus at your hospital as well, but this is how you get all the data for microvascular testing as well as the FFR. So if we have a bridge, then we will go on and test this as well. I use the same pressure wire, so I just leave it in place. I give dobutamine, and we start at 20 mics per kilo per minute, increase it to 40 and go up to 50, which is usually protocols that are used in the stress echo lab. And we're looking to get to a target heart rate of 85%, just like you would have during a stress test. We know that FFR is not sufficient for these because these are dynamic stenoses, not a fixed stenosis like we would do with atherosclerotic disease. And we also know adenosine is not sufficient, which is a vasodilator. You actually need to provoke this inotropy and chronotropy to bring out the physiology that you get from a myocardial bridge. So most of these patients will have a normal adenosine FFR, but they will, if it's significant, their dobutamine, diastolic FFR, and or RFR will not be normal. So stopping with adenosine FFR does not tell you if this bridge is significant or not. So a lot of people ask, well, why should I do all this testing? I'm going to treat them the same anyway. And that's wrong. That's not true. We will treat them differently based on what we find. So testing does guide management. So if you look at the Carmichael trial, so this was really kind of the big trial where they demonstrated that if they found a diagnosis and they basically treated based on that diagnosis, that patients would feel better. And one thing to think about at a very simple level, like if you find out your patient has spasm, well, you're not going to prescribe a beta blocker, right? So you're going to give them a vasodilator of some sort. And if you're, INOCA is the same thing, right? If you find out your patient has myocarditis or SCAD, they don't necessarily need a statin. It's not an atherosclerotic process, right? So you want to know what your patient has. You don't want to put them on meds that they don't need. And while the data for treatment is not great at this point, and you can see if you look at the state-of-the-art reviews, we kind of went through it. There are at least kind of anecdotal ways of doing this. If you do this a long time, you kind of start to figure out what works. But this is definitely an area that we need to keep working on. So the Carmichael trial, if you don't know, had 150 patients. 3/4 of them were women, and all the patients were tested. Here they did not do myocardial bridge testing, but they did get spasm testing as well as microvascular dysfunction testing. And the randomization was to find out your data, your results, or to not find out. And the physicians also either found out or did not find out. In those that were told what their diagnosis was, then there was this recommendation on the management. So if they had vasospastic angina, it was recommended that they quit smoking if they were, take a calcium channel blocker, plus or minus a long-acting nitrate, as well as make any lifestyle changes. If they were found to have microvascular angina, they were recommended to have nebivolol, lifestyle changes, and then consider an ACE and a statin. So in terms of the treatment and what I specifically do, so if I have patients with vasospasm, epicardial, or microvascular, I will tend toward using a calcium channel blocker, again, plus or minus nitrates. If they have a myocardial bridge, we certainly try medical management first with beta blocker. Most commonly, I'll use the nebivolol because of its vasodilatory properties, just because these patients also have a lot of spasm in their bridge. If they have a lot of spasm, I may also give them a nitrate. So that's an old myth that you don't use nitrates in bridges. Actually, a lot of patients feel better if you use nitrates. So if they have spasm, a nitrate's fine with a bridge. Second line therapy for these patients is a calcium channel blocker. If they fail medical management, have a really poor quality of life, then we do offer them surgical unroofing. For microvascular dysfunction, I'd say the data is probably best for ACE inhibitors at this point. ARBs did not seem to be as helpful as ACE inhibitors. Nebivolol also has some data, and as well as Ranexa. And then we know statins and aspirin may be helpful for the endothelium. And also in bridge patients, they invariably have a plaque proximal to their bridge. And this plaque is more prone to rupture. And we know this plaque is likely from basically antegrade flow coming in, as well as retrograde flow from when the bridge squeezes, and that's where the blood flow is hitting and causes a plaque in the artery. So this is our data on surgical unroofing in patients, and this is SAQs before blue and then after in the red. Going higher is better. And so you can see these patients had terrible quality of life and symptoms at baseline, and have a pretty marked improvement when they undergo surgical unroofing. This kind of improvement with the SAQ is more than you will see with stenting or CABG in atherosclerotic patients. So with the Carmichael trial, looking at the diagnostic and clinical utility, the testing, when they did it, changed the diagnosis in about half of the patients, which was important. It also resulted in a significant increase in the diagnosis of a coronary function problem and a decrease in the diagnosis of non-cardiac chest pain. And it increased the certainty of a diagnosis for the physician. So they were 4 times more certain of their diagnosis once they had results of testing. And as a result, they were more likely then to prescribe anti-anginals and tailoring the treatment. And then people also talk about this adding a lot of time. In the Carmichael trial, they said the median procedure time was 60 minutes. And this actually also included randomization. So it certainly should take less than 60 minutes. I find I do the bridge testing as well, and I would say we're probably at about 75 minutes or so with all of that testing to get this done. And I would say that's a short period of time for somebody who's had angina for 10 years. In terms of symptoms and quality of life, in the patients who got a diagnosis and were treated, there were significant improvements in their angina limitation and angina frequency and quality of life at 6 months. There were also significant reductions in their illness perception, so how threatening their illness seemed to them. And there were significant increases in treatment satisfaction. I think the thing that's probably most noteworthy is that those patients who got an angiogram and basically were told they were fine, they weren't told about their diagnosis, they didn't feel any better, right? And this we know, right? So if we keep doing it the way we're doing it and reassuring patients, we're actually not making them feel better. So doing all this stuff is important. So in the Carmichael trial, invasive testing revealed a diagnosis in almost 90% of patients. In looking at my data, I think we were, when I last published, about 75% had a diagnosis when they got tested. So there's a small subset that we don't find anything. And at least at that point, you can feel more comfortable saying it's non-cardiac. They also showed a marked and sustained improvement in angina and quality of life out to 1 year. So in conclusion, INOCA is a common problem that we really have to stop ignoring, and we need to understand that reassurance isn't helpful for these patients. INOCA is not a diagnosis, but it's a working diagnosis that requires a thorough and thoughtful evaluation to identify the underlying etiology or etiologies. Doing invasive coronary function testing can identify an underlying etiology in 75 to 90% of cases. Looking for endothelial dysfunction, coronary vasospasm, myocardial bridging, and coronary microvascular dysfunction. And providing patients with a diagnosis helps guide therapy and improves their angina and quality of life. So I wanted to highlight the microvascular network. So this is a group of providers that we convened in 2001. It was about 50 people at that time. And it was really people from US and Canada who were interested in, promoting this diagnosis and these therapies for these patients. Kind of wanted a better connection and community around this, and also to help start to standardize stuff. Because when we got together, we all found out we're doing it slightly differently. And the end result were these state-of-the-art review papers. So that really came out of this whole group. So a lot of credit to this group for putting that together, because it was challenging to kind of come to an agreement of what we think really represents the state of the art in this day and age. And that's what those papers have done. So this is the central illustration. So that's all you can get. At least I think it covers pretty much everything we went over today. So I think despite the crash, I still have some time for a question and answer. Thank you.
Thank you, Dr. Tremmel, for the very interesting talk. And there was a lot of spirited discussion during the interlude. So I know that there are a lot of questions from our audience, some of which have made the chat. Perhaps, Nora, if you want to ask your question regarding, she posted a question, do you recommend microvascular evaluation in all patients with chest pain and normal coronaries? I think that would be a good question and relevant for a lot of us.
Yeah, I mean, if they, oh, sorry, Nora. Yeah.
No, it certainly is not the standard of practice. And I'm asking, should it not be?
Yeah. It's becoming the standard of practice very quickly. Yes, I mean, it's not one episode of chest pain, right? It's not, obviously you find something else. But I think, these patients come in, they're having recurrent angina. It sounds like angina. We need to give them the benefit of the doubt. They don't typically look like our atherosclerotic patients. Their stress test may be normal, but yes, they have ongoing angina. If you just give them drugs, it's like throwing darts. You might get lucky, so you can always try it. But I think ultimately, even when I've done that with patients who didn't really want to go get tested, we ultimately end up in the lab because they want to know. And it's just, once you know, it's much more easy to figure out what drugs to give them. It does help them to have a diagnosis, right? Any patient with an uncertain diagnosis of any kind has more emotional distress around that. And so there's a lot of benefits to doing it. So I would say absolutely ongoing angina that sounds cardiac needs to have a diagnosis, and we don't let these patients linger for years and years and years anymore.
Okay, thank you. And James, if I can ask my second, or a couple of us actually raised the issue of bridging. And my question there, because I'm actually surprised to hear some of your stats, 60% prevalence in these patients as opposed to the general population.
Yeah.
And so I guess I'm looking for the truth of the physiologic importance of bridging. And my question was myocardial oxygen extraction, which I think is never used. And would that be helpful?
Yeah. Yeah, I mean, I think if we're going to do really hardcore testing, and you could argue, I guess, with any of these, right? You know, put a catheter in the coronary sinus and you speed up their heart and see, you know, if we're making them ischemic and that sort of thing. You know, I think the way this is unfolding is basically we've got all these bridges, and the number, when I published that data originally, that was the one thing that upset everybody. So the same thing that bugs you, right? They're like, this is too many. But it's interesting, if you look at autopsy data, in some studies, they reported 80%. So the range of prevalence has been quite wide. I will say I have the only large database, which we're getting near 1,000 patients, where we did IVUS on every single patient. So WISE didn't do IVUS, the Mayo hasn't been doing IVUS. So nobody has actually looked, you know, serially at INOCA patients with IVUS. So that data is that data. I don't think there's something necessarily weird about that data. I think we don't see these bridges on angio very often. The data and teaching is that you're going to see about 5% of bridges on angiography, which is probably true. CT is obviously a good way. It's traditionally not been called, right? So I don't know if you guys are doing it. When we kind of years ago, I looked, the radiologist said, oh, we don't call them. We see them, we don't call them because, you know, we don't need to pay attention. Now they call them. They also say if they're superficial, deep, et cetera. I think also the kind of outcomes data with unroofing of these patients and having such a marked improvement in symptoms. And these are patients, again, they've been treated with drugs. You know, people have done all sorts of stuff. I've even had some that went for bypass, which we know is not helpful in these patients. And unroofing, you know, improves their symptoms. So I don't think that's all placebo. And I think there is something there as well. So I think it's a very legitimate endotype that we need to pay more attention to. And actually now having this wider microvascular network, it's great because now a lot of people are looking at this and seeing these patients. And it's just become kind of an aha for a lot of people when they haven't been looking before and they're ignoring it.
Thank you.
Yeah.
All right. There are a few more questions in the chat. I saw Dr. Crawford, you had a question. I'm not sure if you want to ask yourself to elaborate, but the question I think was, what is the specificity of an invasive evaluation? I imagine that is getting at, you know, are there cases that are not captured by these therapies, or Are there positive tests that, maybe are not related to the patient's actual symptoms?
Yeah, I mean, that's a hard one, right? Because we don't have controls, right? We all want to have controls, and we don't. So I can't take normal people to the cath lab and do all this stuff. It would be great. That'd be a great study, but they're not going to allow me to do that. So yeah, so the question is, well, if I took somebody normal into the cath lab and gave them acetylcholine, would their artery constrict 90%? So there's going to be, I'm sure, some patients where we have false positive, false negative. Interestingly, we got a paper coming out that looked, we typically just look in the LAD. And this paper, which was by my colleague in Australia, said, oh, what if we look in all three arteries? And it turned out that if you look in all three vessels, there are actually a certain proportion of patients where you will find something when you would have said there was nothing, right? So false negatives is a problem as well. If I only do the LAD, I'm missing a certain proportion of patients' spasm and microvascular dysfunction that maybe is in the right or the circ. So moving forward, there's probably going to be a recommendation that if you don't find anything in the LAD, you need to look in the other vessels. These patients have angina. I mean, if you listen, they have angina, and these are normal people with angina, or normal people before they had angina, and now their lives are limited. So something's wrong. Again, some of these tests, maybe they don't actually have it and I found it, but the vast majority of these patients, something's not right, and we can help make them feel better. Time for one more, or should we?
Yeah, that sounds great. If anyone else has a question, please feel free to unmute. I know that we have a number of members of our interventional team here.
Yeah, actually, I have a question. I'm just kind of curious, like, where you guys are with this, and are there kind of hopes of getting this going at UCSF?
Sure, I can speak to that a little bit. I'm Christian, one of the interventional cardiologists. So we've been doing the vasoreactivity testing with acetylcholine for a while, but we haven't had the invasive measurement. We're in the process of getting CoreFlow, and once we get that, I think hoping to sort of kick off the invasive portion. I think the other piece is really important, sort of educating the community of folks for this among general cardiology and identifying this and then getting the patients referred for the right evaluation. And I think this talk is a great segue into doing that. And there's a number of our non-invasive cardiologists who are interested in this patient population as well.
Yeah, it really takes a whole change in mindset, right? So everybody has these patients in clinic, and we have to kind of look at them afresh, right? And especially when you have all this going, these will be perfect patients to evaluate and hopefully help. And definitely, we would like to get you hooked up in the microvascular network. I'd love to have you as a part, and hopefully kind of help you guys get going. And when you have cases that you're unclear about or whatever, love to have you as a part of it.
That would be amazing. We'd love to join you, and we'll connect offline. Thank you.
I have a question. Jen, do you have any sense of the frequency with which these tests are done in non-academic centers?
Yeah, it's lower, but we definitely made a point of, in the microvascular network, getting non-academic centers, because they do exist, and there are groups that get really, involved in it and create a great program. I don't have exact numbers, but I mean, certainly one of the goals was to have some center in kind of close vicinity, so you don't have these big deserts, right, where patients have to travel 4+ hours. We still have desert kind of in the what part of it's kind of the West Coast, but not all the way to the coast, right? Middle West. So there are still some deserts, but it's mostly academic centers, but there are definitely people that are non-academic centers that are big that are doing this as well. So hopefully, again, we have enough places that everybody can get help around the country. Well, I thank you so much. I really appreciate being a part of your grand rounds today. And I hope that it was helpful for you guys, and certainly am enthusiastic about your efforts moving forward.
Well, thank you, Dr. Tremmel, and thank you for everyone's participation. We'll see everyone at next week's Grand Rounds.